Hello, I'm Dr. Gerald Chodak for ProstateVideos.com. In this video, I want to talk about managing a rising PSA following radical prostatectomy. Certainly something that happens in about 20 to 30% of men undergoing that operation. The bottom line message to you is that there are a number of options, but there's considerable uncertainty about whether or not it's worth doing. So first, let's talk about those men who do have a rise and some of the factors that are worth considering. Not all men with a rising PSA after surgery are in trouble. It depends on several things. It depends on when the PSA starts going up. It depends on how fast it's going up. And it partly depends on the kind of tumor that was found at the time of surgery. So we have found out that if a man has a long delay before the PSA is rising, and it's going up relatively slowly, meaning it's doubling in, say, 9 months, 12 months, or longer, those men may have very little risk of dying from their disease, even if they don't get any additional therapy. Those men that are most in danger are those whose PSA goes up within 3 years of their operation and doubles in 3 months or less, and those men that had a high Gleason score at the time of their operation. So we can separate men into a relatively low risk, intermediate, and high risk group in terms of the danger they may face with a rising PSA. Now, there has been a good study that was done looking at giving radiation therapy for a rising PSA. And the results show maybe some benefit, but it took about 13 years to see it. And it helped only a small number of the men who actually got that treatment. And it does add to the side effects. So it is an option, but the question is, when does it have to be administered? And it probably has to be administered before the PSA reaches 1 nanogram per ml. We'd like to know whether you have metastatic disease, and the problem is that when the PSA is very low, doing a bone scan or a CAT scan or any other test is not very reliable for telling where the cancer might be located. Giving you radiation therapy when cancer cells are somewhere else in the body beside the pelvis is not likely to offer you any benefit. It may add to your side effects. So the question is, why bother? So the information that we have about giving postoperative radiation, we have some, it's limited, it has pros and cons. The other option to consider is hormone therapy, either continuously or intermittently. And there too, we don't have a lot of long-term good studies that can tell us whether adding hormone therapy early is going to improve your survival. Many men will wait until they become symptomatic, or certainly until there's further evidence of disease progression before embarking on hormone therapy, or at least wait until we have significant increases in the PSA. So is it right to go on hormone therapy when your PSA is 1 or 5 or 10 or 20? Those are questions that you have to discuss with your doctor, but realize that we have no studies that can tell us for sure when is the best time to initiate hormone therapy in this setting. I think that men who want to be aggressive will do it early. Men that want to be more conservative and avoid the side effects of hormone therapy can wait until a longer period of time. Certainly, if you have a rapid PSA doubling time, you're going to end up with a need for treatment sooner than if a man has a slowly doubling PSA. And there are things you can do to check on your PSA doubling time before you make a decision. At least you realize that if you've been treated with surgery and your PSA is rising, you certainly have time to make a decision and consider whether or not it's something you really need to do, or whether or not you can delay this treatment and continue to monitor your PSA. So aside from those treatments, there really is no other options. You can't consider other forms of radiotherapy like putting in seeds, because there's not anything to put them into. But your options, therefore, are limited to either radiation therapy or hormone therapy, continuously or as an intermittent basis. The idea of doing intermittent hormone therapy is we'll lower your PSA and keep it in check, and maybe it will delay disease progression. But at this time, there's limited information to know whether intermittent therapy is better or as good as continuous therapy. It does have the advantage of limiting your side effects, and that can be an advantage. So if you do go on hormone therapy, you can either block the hormones from the testicles with an LHRH agonist or antagonist, or some men will take what's called an anti-androgen that blocks the action of the hormones. Whether one is better than the other has never been well studied in men with a rising PSA after surgery. So the bottom line here is you have options, but unfortunately we have limited information to be able to say to you that clearly one is a better way to go than another. Hopefully you'll find this information helpful, and thank you for watching.